Welcome to the first ever episode of the Cleveland Clinic London podcast. I'm your host. My name is Kash Akhtar, and our special guest today is Paul Jarman. Dr. Paul Jarman is a consultant neurologist and chair of Department of Neurology at Cleveland Clinic London. Paul is a clinical neurologist with an interest in all aspects of neurology and brain disorders, particularly movement disorders such as Parkinson's disease, and in headache, migraine, and acute neurology. Today's episode is all about dementia, something that's once was just considered to be a normal part of aging and almost taboo, but now it's increasingly topical, increasingly talked about in wider circles rather than hushed tones. So Paul, I'm an orthopaedic surgeon, so I think I'm best placed to ask all the questions that the non-medics would want to know. So do you mind kicking us off? Could you define what is dementia exactly?
Thanks, Kash. Yes, so dementia, everybody in a way, has heard the word dementia and knows a little bit about it. And you can think of dementia as a clinical syndrome. It's not a single disorder. There's probably more than 100 different causes of dementia. But in simple terms, it is a progressive failure, usually a slowly progressive failure, of those parts of the brain that deal with cognitive function, by which I mean memory and thinking, those sort of aspects.
Right.
But if you want to define it a little bit more technically, then it is a significant impairment of at least two aspects of cognitive function. Usually memory is one of those, but not always. But it can be language, it can be reasoning, judgment, ability to problem solve. So a significant decline over baseline in two aspects of cognitive function that reaches a certain threshold of severity. It has to be enough that it's affecting everyday functioning, making a significant difference to that person's life and to the life of people around them. So at that point, one would call it dementia. Whereas if somebody has milder symptoms, then we would call it mild cognitive impairment, which is often shortened to MCI.
Okay. And is it fair to assume that it is a normal part of aging?
No, it's absolutely not a normal part of aging. It was thought that in the past, but we now know that it's nothing normal about it.
Okay. And can we all expect to get it at some point?
No, not at all. Not everybody gets dementia. It's an age-related thing. So certainly in high-income societies, the average age of death is going steadily up, and so people are more vulnerable to age-related neurodegenerative disorders.
Right.
So it's very much an age-related thing for many of these conditions, Alzheimer's disease, for example.
And I was going to say Alzheimer's is probably Alzheimer's dementia is a phrase that people have heard a lot over the years. And so that's one of the most common ones. What are some of the other ones?
Yes, Alzheimer's is definitely the commonest. It's about 2/3 of all dementia cases are Alzheimer's disease, but there are many others. There's vascular dementia, which means essentially a series of small strokes and furring up of the very small blood vessels that supply the brain, particularly the very small arteries that penetrate deep into the brain. There is Parkinson's disease dementia. So dementia that occurs after a number of years of Parkinson's disease, which is closely related to Lewy body dementia. Lewy bodies being the little microscopic particles that you can see under a microscope in the brain. There's frontotemporal dementia. Now, there are quite a number of different forms of dementia, and there are many other sort of, rather more small print forms as well.
And is frontotemporal, is that one where people are a bit more disinhibited?
Yes, that's definitely one way that it can present. So frontotemporal dementia is quite a complex condition. It can be a little difficult to diagnose sometimes, but it presents in one of two ways, broadly speaking. Either what's called a behavioral variant where people's behavior starts to change and, they become disinhibited, their judgment changes, they, might become, rude to people in a way they weren't before. They may, lack sympathy for other people and compassion. And so they change their behavior.
We call those people spine surgeons.
Definitely not orthopaedic surgeons.
Definitely not orthopedics, no. We shouldn't do.
Exactly. And then the other form is a language form in which language is affected.
Right.
So there are various subtypes of that, but we sometimes lump those together as primary progressive aphasia, so a progressive loss of language function.
Okay. And can you have more than one type of dementia?
Yes, you can. That's an interesting question because it seems that we always think of dementia as being individual diseases like Alzheimer's disease, vascular disease, but I think it is clear increasingly that these different forms coexist as people get older. For younger people, that may have more genetically based forms of dementia. It may be a pure form of dementia, Alzheimer's disease, Huntington's disease, for example, frontotemporal dementia. They can all be genetic in nature. But with the aging process, people can have multiple pathologies. So they can have 2 or 3 pathologies. They may have Alzheimer pathology in the brain. They may have vascular disease contributing. And you may have other pathologies as well. And we see this at post-mortem studies.
Right. And I was just wondering, are there more specific groups of people who are more prone to get certain types of dementia?
Yes. I mean, a big part of the risk of dementia, certainly for Alzheimer's disease, but for the other neurodegenerative forms of dementia as well, is genetic. So there are probably, multiple genetic factors. So we know that for Alzheimer's disease, there are some rare genes that give you a very high chance of getting dementia, of Alzheimer's dementia, probably 3 or 4 of those very rare genes. But then there are very common genetic variants in the population that give you not such a high risk, but still a significantly increased risk. And one of those is called ApoE, the ApoE gene. There are probably 70 or more genes that are linked to Alzheimer's disease. So although many people have a family history of Alzheimer's disease simply because it's so common, you don't necessarily have to have a family history for it to be genetic, because the combination of genes that you get from your mother and father, those risk factors may add together to give you a risk of, a higher risk of Alzheimer's disease. And if you live long enough, then that eventually develops. If you don't live long enough, it may not develop. But then there are probably lifestyle factors as well that determine risk. It is thought that perhaps 50% of risk of dementia might be due to lifestyle factors.
Just talking about symptoms, so you've touched on some of the early and late stage symptoms, which can involve memory loss, confusion, language problems.
Yeah.
And then there are the behavioral psychological aspects of aggression or depression. Are there any other symptoms or any red flag symptoms that people should look out for?
Yeah, so the symptoms are generally very insidious because it is a very slowly progressive condition. If you take Alzheimer's disease, for example, the commonest form, of dementia, as I mentioned earlier, it comes on extremely slowly, and we might unpack that a little bit later on, because there's probably a prodromal period, by which I mean a period without any symptoms, that may go on for 20 years before the first symptoms appear. So, when does it start? Well, it starts in the brain many years before the symptoms occur, and the symptoms come on very gradually, and the individual who has those symptoms won't always be aware of them themselves. So they may have gradually worsening forgetfulness, but they won't necessarily be aware of it. Sometimes they will, but it may be the other people around them that really notice it. So if you take memory, for example, forgetfulness, so people with Alzheimer's disease, the commonest early symptom is just being a bit more forgetful. Now, not the normal forgetfulness that we always have when, you go upstairs and you think, what was I looking for up here, or where did I put my keys? That's normal forgetfulness. But people's memory may be just less efficient for remembering things. So conversations that they had, or a set of instructions they were given to meet at a train station or something like that. Those sort of things are less reliable. And there's what's called a temporal gradient. So it really affects memory for recent things. That person may remember what they did 20 years ago very clearly, but what they're not so good at remembering is what they had for breakfast that morning, or what they did the previous day. So it's a less reliable memory for recent events.
So that almost sounds as though that there is that something that happened a long time ago is set in stone.
That's right.
And the memory is cemented. With something recent, you can't reinforce that memory. Was that fair?
No, exactly. And that's right. I mean, memory, memory is a complex thing. You have to be able to encode it. So you have to actually make the synapses that you require for memory. And then you have to store it safely so it remains there. And then you have to be able to retrieve it when you need it. So those are the sort of different steps. But distant memories, so they're hardwired into the brain, literally. They're, those synapses are there, those connections are there, so the memories are there, and people can still access those. But it's the ability to make new memories, to form the synaptic connections that you need and increase the strength of those synaptic connections that forms a new memory, and it's that's disrupted.
I guess one of the challenges with the symptoms you described coming over such a long period of time, years, potentially decades, is that those changes in behavior and in memory can be so gradual
Yes.
that even to family members, they may not pick it up, because it's just something that's happened so many times for so long. And then if you go up to someone and you say, well, actually, you're getting forgetful, human nature might be to be quite defensive about it, and to be quite a difficult discussion to have as a family.
That's exactly right. I mean, it does come on so gradually, and people sort of compensate for it to some extent. And there's this concept of cognitive reserve where you're able to kind of compensate for changes in the brain. Particularly, people who have a high educational attainment, for example, are good at that. But many people have a very good social facade. So in a conversation with somebody, you may not notice anything. You talk about this and that and the weather, and they've got all of the right sort of social cues and mannerisms, and they'll laugh and smile and respond appropriately. But if you actually dig down and say, well, what's the date today, and what is the address that we're at, and what year are we in, and if you dig down into that specific detail, then actually they may not be so good at those things compared to just a sort of a very social conversation. But it's a much wider problem than just memory. I mean, memory is, if you like, the first thing that's typically affected, but its ability to process information, its ability to sort of deal with multi-step instructions or complex tasks. So, for example, cooking a meal, it's quite a complex thing. You have to sort of follow a sequence of procedures and chop the onions first and then fry them at the right temperature and then do this and that. Similarly, traveling, planning a trip, that's it's a multi-step thing that you need to, a whole series of steps in the correct sequence in the right way.
Yeah.
So all of those things just become a little bit more difficult, a bit less reliable. And people may notice, for example, they're just not so good at technology. So they're not so good with their mobile phones, or they're not so good at emails, or they may find it more difficult to remember words, the richness of their language and their vocabulary. So, for example, there have been studies of famous writers who developed Alzheimer's disease. And if you look at their books, you can see that the richness of their vocabulary changes as their brain changes.
I must say, when you mentioned the fact that cooking, that got me concerned because I'm a terrible cook. If you tell me that doing laundry is first sign of dementia, struggling with that, then my wife.
That's right. If you can't hoover, Kash, then you're in trouble.
Well, that's why I got robot hoovers. How big a problem is dementia?
It's a big problem. It's a big problem for society. It's a big problem for individuals, and it's a growing problem. Alzheimer's disease is the commonest age-related brain disorder. So it's because we're living longer, and we're also better at diagnosing it. We are able to spot it. We have tests that allow us to diagnose it. So it is a big problem because it's more common, but it's also a big problem because it's extremely disruptive. I mean, having a broken hip. My mother broke her hip this week, and it's a terrible thing, and she's out of action. But a brilliant orthopedic surgeon did an operation, fixed it, and she's up on her feet now. And you guys put people back together, and
but that's the beauty of orthopedics.
That is the beauty of orthopedics.
I'm glad you're seeing it, Paul.
But with the brain, it's it affects every aspect of one's life and the people and your spouse's wife, your children, the people around you.
A much wider burden on people around. And I guess if people live in longer, people will need support to be in safe environments. It must be a hell of an economic burden.
Well, it is a big, you're right, it's a big economic burden. I mean, in the UK, there are probably about 1 million people with dementia.
Right.
In the US, there are probably, with Alzheimer's dementia, probably 6 to 7 million people. Now, if you look at the costs of that, quite apart from, the individual, sort of sadness of that for the families, but, if you just look at, if you take an economic view and look at the costs, in the US, I think in 2023, the costs of dementia care were $325 billion. And of that $325 billion, less than 2% is medical care, by which I mean treatments, medication. So
where is the 98% getting? Is it on social care?
It's social care, essentially. It's the care in nursing homes and that sort of thing. It's carers coming around to people's homes.
Yeah.
That's what most of it goes on. So it's it's a big effect on costs to society, but productivity of society as well.
Yeah, I mean, if if children or spouses are then unable to go to work to meaningfully contribute to the economic society, then that has a big knock-on effect, let alone the human cost of it.
That's right. No, exactly. And this is not talking about the human cost, which is in a way the bigger tragedy for everybody that's affected. So you can't hard to quantify that. It's an individual thing, but in terms of putting numbers on it, it's a huge economic cost.
Can we talk about kind of what happens to the brain in dementia? Going back a long way to medical school, I remember something about amyloid, and that's about as much as I remember. And being an orthopaedic surgeon, I've just parked it and I've not gone back to amyloid. But that's one thing that rings a bell, and something about tau proteins. Would you mind? So what happens in the brain structurally?
Well, I mean, we know quite a lot about the underlying basis of many dementias. And if we take Alzheimer's disease, then, we know quite a lot about it. It was first described, I think, in about 1907 by Alzheimer. And he described these abnormalities in the brain of a woman who developed Alzheimer's disease relatively young. And in fact, we know that person had a particular genetic form of Alzheimer's disease now, one of these rare forms. But so it was over 100 years ago that the brain pathology was first described. And the brain pathology is very specific to the condition. So there are two main abnormalities. So there are what are called amyloid plaques, and then there are neurofibrillary tangles. And amyloid is deposition of protein in clumps, in sheets, beta-pleated sheets. The individual fibrils of protein all stick together and form these gradually increasing clumps. And we know now that contains amyloid beta, which is part of a protein called the amyloid precursor protein, or APP, it's just called. It's a transmembrane protein. And it gets chopped up by little enzymes, secretase enzymes, into fragments. And some of those fragments at a particular length of amino acids are not very soluble. And so they tend over time to just polymerize, to stick to each other, and those little seeds become gradually larger. And probably that is the first abnormal process that takes place in the brain, because we know that anything that gives you more A-beta, more of this APP protein. So, for example, Down syndrome, trisomy 21, the APP gene lives on chromosome 21. And there are 3 copies of chromosome 21 with Down syndrome. And so those individuals, rather than having the normal 2 copies of this gene, they have 3. So it's what's called a dosage effect. So they have an extra amount of APP. And therefore, because there's more of it, it tends to get deposited and to clump together. And people now that the care for people with Down syndrome is so good, from a cardiac point of view, they live much longer. And they're much more likely to develop Alzheimer's disease as a result. But also we know that genetic mutations within the APP protein gene, or within the genes of the enzymes that cleave the APP protein, will cause Alzheimer's disease as well. So we know that that amyloid plaque is very important, and it seems to be probably the first thing. There was always a debate, is it the amyloid or is it the tau neurofibrillary tangles that's the key thing? But I think most people now think that this amyloid, because amyloid can form in any organ of the body, but this particular form of amyloid, it forms in the brain. It seems to disrupt the cells, the brain cells and the synapses. And then it leads eventually to tau, which is another protein which is inside the neurons, inside the brain cells. And that forms these things called neurofibrillary tangles, which are made of what's called hyperphosphorylated tau. And tau is the protein that's in the microtubules that allow the various constituents to go along the long neuron to be passed up and down it. So you get the amyloid forming first, and then you get the tau pathology within the brain cells, and then you start to lose synapses, and then you lose brain cells. So brain cells start to die essentially, and you can see that on a brain scan eventually as atrophy, as a reduction in the size of the brain. I'm afraid, as we get older, our brain does become we lose a little bit of brain all
Shrinks
the time.
A bit,
Probably a cubic centimetre per year after a certain age in adulthood. But with Alzheimer's disease, you lose much more, and you can see that on an MRI scan of the brain.
What age does it start?
Well, for For the genetic forms, it starts very early, but for most people, it's a late onset thing. So if you look at people, say between the age of 65 and 75, about 5% of people will have Alzheimer's disease.
Right.
If you look at people in the next decade up, from 75 to 85, that almost triples to about 13%. And then if you look at people in the next decade up, 85 and above, everybody 85 and above, it getting on for triples again, at least doubles. So over the age of 85, about 30 to 35% of people have Alzheimer's disease. So incredibly common.
And as you say, that's predominantly the Alzheimer's form.
Yes.
And I can understand how with the vascular form, if you've got furring of the pipes, as it were, the flow through the pipes will be turbulent, will be less. And so that can result in
bits of the brain will be sort of
downstream.
starved of oxygen, if you like, starved of blood supply. And probably those two things, the Alzheimer changes and the vascular changes, occurring in tandem for a lot of people. And both causing damage of different, slightly different sorts of damage, but they're combining to affect the way the brain works.
And the loss of neuronal connections also, I almost visualize it as one of those satellite pictures of, looking down at a country from space, and all the lights are on at night, and then some of the lights start going out. That's how a simple orthopod would view loss of neuronal connections.
That's a good way of looking at it, yeah. And there are something like 86 billion neurons in the brain. It's incredible. And so there is a certain amount of cognitive reserve. You can lose some of those neurons and still function perfectly well because you don't need every single one all the time.
Yeah.
And so, a lot of our brain networks will have a certain level of redundancy built into them, so they can still function even with a certain amount of damage. But you eventually get to a threshold where it starts to affect function. And what's interesting about it is this kind of concept of this prodromal phase. So the way in which these changes are occurring in the brain without any symptoms at all for decades. And what's interesting is that if you follow up people who are known to have a genetic mutation that will cause Alzheimer's disease. So, this is a relatively small number of people, but that those individuals will get Alzheimer's disease because they've got a particular genetic form, and you follow them up. You can see that they're starting to get this amyloid deposited in the brain 15 or 20 years before their first symptoms appear.
Right.
And they are starting to get tau 5 or 10 years after that appearing in the brain. And then a few years after that, if you measure memory and other things, you see that that's not quite as good as it was, but at that point they still don't have any symptoms. So there's this long silent period in which things are developing in the brain and slowly getting worse. And then eventually you reach a threshold where the changes in the brain are enough that the symptoms are there.
Yeah. And it almost seems to me that once you're picking up memory problems, it's very late on in the process.
Yeah, well, it's certainly, the process has been there for a long time. Now, those, if there was some way of arresting the process at that point, then, you would be left with people, who have got mild memory problems but are functioning perfectly well.
Who haven't progressed.
Mild cognitive impairment.
Yeah.
But if you could somehow, and there are ways of doing this, detect it before
in that pre-symptomatic phase.
In that pre-symptomatic phase.
Yeah.
If you could detect it, and there are ways of doing that, before there are any symptoms, if one had if some of these new treatments in the future proved to be effective at slowing progression, or even stopping progression, or delaying the onset of these symptoms, that would make a significant difference if you treat people before they become symptomatic. Now, that's not something that's happening at the moment, but that's something people are talking about.
So let's talk about diagnosis and tests. How do you diagnose it?
Well, the first thing is you need somebody who knows about the condition, and generally it's either a neurologist or an old age psychiatrist or a geriatrician, a care of the elderly physician, to take a careful history. And you really need to get a history from those people around them. So, their husband or wife, or, their children sometimes, because they will notice something different. Sometimes the individual will say, well, there's nothing wrong with my memory. I don't know why I'm here at all, Doc. Whereas, the wife might be saying, well,
someone
actually,
along,
he's very forgetful, and I insisted that he came here, sort of thing. So taking a history is by far the most important thing. You can then do a bedside examination of cognitive function. So there are a lot of standard sort of instruments, as we call them, for doing that. So essentially for testing memory, for testing language, and getting a score.
The mini mental test score is the only one that I know of.
Yeah, so the MMSE mini mental state examination is one, and there's the Adam Brooks cognitive examination, and there's the Montreal, etc. So there's a series of them. They take 10 minutes, 15 minutes to do, not very long. And there's a few other simpler ones, just 10 questions. The mini MTS has got 10 questions, but so. People would usually do those and, ask specifically things about, what is today's date? What is the month? What is the year? What day of the week is it? Where are we? What floor of the building are we on? Those kind of orientation questions, and then some memory questions. And then it's really important as well to be sure that person isn't depressed. Depression isn't the cause for their memory problems. And that's, because things like depression can present almost like dementia sometimes. So there's the history, there's the examination, and then there are the tests. And we would normally do some blood tests, make sure that the thyroid isn't underactive, make sure that vitamin B12 isn't too low, because all of those things can affect brain function. We want to know a bit about alcohol history and whether, somebody who's drinking a lot of alcohol and not eating very much, they might be deficient in thiamine, which is vitamin B1, and that certainly affects brain function. But then we would usually do some kind of brain imaging. So that would usually be an MRI scan. And there are two reasons to do that. Firstly, to make sure that there isn't, a structural abnormality of the brain. There isn't
a stroke.
There isn't a big stroke, or that there isn't a brain tumor, maybe a benign brain tumor like a meningioma putting pressure on the brain. Make sure there isn't excessive fluid called hydrocephalus, for normal pressure hydrocephalus. Make sure there isn't a bleed like a subdural hematoma from somebody that's fallen over. So you want to do that. But you also
would actually present in exactly the same way.
It can do, yeah. So somebody's had a subdural hematoma with blood over the surface of the brain pressing on it over a series of months may just have a gradual decline in their cognitive function. So the imaging is important for that reason, but it's also important because it tells us about the brain structure. It's a very high resolution an MRI scan, and so you can see if there's shrinkage of the brain greater than you would expect for age, because of course you have to take into account that person's age, because you can sort of age somebody just by looking at their brain MRI. Actually, you can somebody who's 21 and somebody who's 80, their brain scans just look different in healthy people. So you want to see if there is greater than you would expect shrinkage, particularly of the memory parts of the brain, so the temporal lobe and the hippocampus. Although you can still have Alzheimer's disease when they look completely normal, because those changes tend to occur a little bit later. You get the symptoms before you get the clearly visible changes. So that's the main way it's done. But we now have some more, even more sophisticated and specific ways of diagnosing Alzheimer's, because sometimes you can take the history and do the examination and say, well, this is the clinical picture of Alzheimer's disease. My diagnosis is Alzheimer's disease, and generally somebody who's an experienced clinician will be right the majority of times. But increasingly, there is a need or a desire to do a specific test for Alzheimer's disease, and that's particularly in the context of these new treatments that are available, where we really need to know, is it Alzheimer's disease or is it something else? And
these would be blood biomarkers?
Well, there's different ways, yes. So the first one that was developed was spinal fluid. So with a spinal tap or a lumbar puncture, you can take a small sample of spinal fluid, you send it to the lab, and you actually measure the A-beta protein, and you can measure the tau protein, and they're abnormal, and that's a very sensitive test. It's clearly abnormal from the earlier stages. Or you can do, but it's slightly invasive, having a lumbar puncture or spinal tap. A lot of people don't really want to do that. Generally it doesn't hurt if you do it right with a local anesthetic and so on, but it is somewhat invasive. So there is a thing called an amyloid PET scan now. So that uses a radioactively labeled tracer compound that binds onto the amyloid in the brain. And you can see from the very earliest symptoms that there's a lot of amyloid in the brain when it binds to that. The radioactively labeled tracer binds to it, and can see that. It lights up. The problem is that there aren't that many PET scanners in the country, and most most countries don't have a huge number of these PET scanners, so it's not that easily available to everybody, particularly in more rural areas. Big hospitals have them. But the thing that has changed, or we're on the cusp of a change, is that there are now blood-based biomarkers. So the technology is so sophisticated now that you can measure the tau, the abnormal tau in the blood, in tiny quantities, picomole quantities,
right,
and also the A beta 40 and 42, and those blood tests are so sensitive that you can diagnose Alzheimer's disease on some of these new blood tests that are just starting to come through. They're not routinely available in clinical practice, but the FDA have approved some of them. There are others coming through right now, and I think within a very short time, these will be very widely available. Essentially, tests, a blood test for Alzheimer's disease.
Right. And when we're talking about testing, is there any role for genetic testing?
Yeah. So that is not something that one would do for everybody.
Yeah.
So with genetic testing, and somebody who's unusually young with Alzheimer's disease, then genetic testing would definitely be important, because the younger you are when you get Alzheimer's disease, the more likely it's one of these purely genetic forms called monogenic forms. The older you are, the smaller the genetic element, or the more complex the genetic element. So, but with this particular gene, ApoE, which I mentioned earlier on, we all have the ApoE gene, of course. We have 2 copies of it, one from the mother, one from the father, and it comes in different forms, and there are different variations in the gene. So we call those variations E2, E3, and E4. And this E4 type of the gene, if you carry one of these E4, what's called an allele, the E4, one copy of the E4 version, then you have a higher risk of Alzheimer's disease. If you carry 2 copies, then you have a very high risk, about a 90% risk. So we sometimes do that where we're considering these new treatments, because the genetic type for ApoE depends on the risk it gives you some information about the risk of the treatment. That's why we do it. But it is sometimes done as a predictor of risk for Alzheimer's disease, but it's not done very much, because some people will want to know, they'll go to 23andMe and, send off their DNA and get a blood test, and it tells you a bit about what, your ancestry might be and so on. Yeah. But there is a bit where you can look at your ApoE status and find out whether you're high risk or not. But because until very recently, there haven't been any effective treatments.
You couldn't do anything about it anyway.
You can't
so
do
why
anything about
do you
it.
want to know?
So what do you want to know? And that's, some people want to know and some people don't.
Yeah. One thing that's interesting I'm finding increasingly in medicine's always, for the last 50 years or so, has been about treatment and intervention. And now increasingly there's focus on prevention.
Yeah.
So can we prevent dementia?
To some extent, yes.
Please tell me how.
Not living very long is one way.
Anything else? Anything more actionable?
Yes. So lifestyle factors are important, and they're the kind of things that everybody knows about in a way. So if you think about cardiovascular risk factors, so things like high blood pressure, smoking, being overweight, not exercising, having diabetes that's not well controlled, having high cholesterol, for example. All of those are vascular risk factors. They cause atherosclerosis, they cause furring up of arteries, and that affects the heart and gives you a risk of heart attack, but it also affects the blood supply to the brain. And so all of those things are risk factors for dementia, mainly because they affect the blood supply to the brain. So they are definitely important. So those are all risk factors. I think it's probably actually more complicated than that. I mean, that's the simple explanation. I suspect there's more to it than that with those cardiovascular risk factors, because I have this sort of theory, which I think there's some evidence for, that exercise, for example, releases factors in the brain, probably neurotrophic factors that help to keep neurons healthy, that help to repair damage and so on.
Is that why you run marathons?
Yeah, that's not the main reason.
Okay.
No, that's not the main reason. But so there's something about exercise that is protective for the brain, and we see that in Parkinson's, for example. There's no doubt about it.
Protective for so many things, bone health, muscle health,
it's
heart,
kind of win-win,
lungs,
apart from whether your knees go or not.
Yeah,
but,
we can fix those.
Exactly. So there's so there's no doubt that cardiovascular risk factors are important in the risk of dementia. That's that is for sure. But there are other things as well. So there's increasing emphasis on the importance of sleep.
Yeah.
So we now know that sleep is probably, good sleep is probably protective for the brain. And what seems to happen during sleep is that this system, a bit like the lymphatic system called the glymphatic system in the brain, when you're asleep, it sort of opens up and it sort of probably cleanses it, to put it simply, some of the toxins that accumulate in the brain, some of the abnormal proteins, the misfolded proteins that accumulate.
Time for the body to do clean up and
right, and
correct.
They're probably removed by this system overnight. And there is increasing evidence that people who sleep very poorly, for whatever reason, maybe they're night shift workers or they are people who have very poor sleep, there is probably an increased risk of neurodegenerative disorders, and we see this in animal models as well. So there's something about sleep. If you think of Margaret Thatcher, who famously slept very little, she developed Alzheimer's disease. I mean, that's not necessarily a cause and effect, but she, in later life, unfortunately, did develop Alzheimer's disease. So there is something about sleep that is very healthy for the brain and protective for the brain. So sleep is important.
And sleep hygiene, all these things we're recognizing increasingly as valuable for health in so many factors.
Correct.
In fact, we're going to do a podcast on sleep, so we will come back to that.
It's really important, yeah. So there's much more emphasis on sleep as being something that's not just some passive thing that happens, but there are active recovery processes occurring during sleep. But then, there are other things as well. There are probably toxins in the environment. So probably pollution is related to risk, we think. And for some neurodegenerative diseases like Parkinson's, there is some evidence that pesticides and herbicides may be causative. We know that, smoking and alcohol, are not good for the brain. So, and then the final one, once you've considered all of those sort of, toxic things and lifestyle factors, the final one is hearing and deafness. So there seems to be a link between having poor hearing, particularly as people get older, and risk of dementia. And the question at the moment is that just a social thing, that you don't have so much sort of social input, you can't really take part in, back and forth, quick conversation.
And stimulation where you're working your neurons.
Right. Is it something to do with stimulation, or is it more than that? Is there something about losing the input from hearing that actually causes neurodegeneration? So, but there is certainly a link. And so we very much encourage people to use hearing aids and to, sort out any deafness that they may have. And then perhaps the final thing is, certain drugs, certain medications, anticholinergic drugs, for example, drugs that block acetylcholine in the brain, they affect cognitive function to some extent.
Which drugs are those? You have to spell it out for me, I'm afraid.
Well, there are quite a few drugs, actually, that to a greater or lesser extent can do it. There are certain categories of Parkinson's drug that can do it. Some of the older antidepressants can do it. But there are quite a few. There are quite a few drugs, amitriptyline, which is used for chronic pain, for example. There are quite a few drugs that just reduce, they block the effect of acetylcholine. And we know that with Alzheimer's disease, there is a deficiency of acetylcholine. And that is probably reversible. If you stop those drugs, it can improve cognitive function. If you go on them, it can worsen it.
Okay. So can we talk about the treatments? Because we've touched on them. Because I'd like to know kind of what the current state of play is with regards to the treatments that are available now. And then there's some new breakthrough, wonder drugs coming through. And I'd like to just talk about those.
Sure. Yeah. So, people sometimes think that Alzheimer's disease is untreatable, but it's not. There are treatments. We've for about 20 or 30 years now, we've had medications that I call cognitive enhancing drugs. So they enhance cognitive function. So the main group are called cholinesterase inhibitors. So they inhibit the enzyme acetylcholinesterase in the brain, and they therefore increase acetylcholine in the brain. Acetylcholine is a very important neurotransmitter. We know that the levels are too low with Alzheimer's disease. And these medications boost the acetylcholine neurotransmitter levels in the brain. And they give a boost to cognitive function. They improve concentration and memory and attention and so on. And for some people, they see, a significant boost in their functioning. Now, it's a modest boost. They're not transformational. They don't return people to normal. On average, people who take these drugs will be a little bit like they were 6 months before. But that is just an average. There are some people that get very little obvious response. There are other people that get, really quite a big boost. Those medications boost the cognitive function when you're taking them. They help. But what they cannot do is slow the progression. There are some new drugs now available which actually do, they're what are called disease-modifying drugs. So they slow the rate of progression. So they actually modify the progress of the disease.
And so that's revolutionary. That's a game changer.
It is. Well, it's the beginning of a new era. So these are very new drugs. They've been a long time in the coming. They are based on really understanding how important amyloid is in the brain. And it was about 25 years ago that people started to do experiments initially on transgenic mice with sort of Alzheimer's disease, where you immunize those mice with the amyloid, basically. So you make them create an immune response, and what would happen is that they would produce antibodies against the amyloid because you'd make it into a sort of a vaccine. And those antibodies would actually clear a lot of the amyloid in the brain. They'd just get into the brain and remove it.
Right.
And so that was then done in humans. Unfortunately, it had some side effects because it caused a lot of brain inflammation as those antibodies got into the brain and caused inflammation. In about 5 or 6% of people, they developed an encephalitis. And so those studies were stopped. Actually, the amyloid was clearing from their brain. And so, if you like, it's a sort of proof of principle that if you remove the amyloid, or at least you can remove the amyloid with antibodies, and then the question became, does that actually change what happens clinically? Does it make a difference? And then, so the way that was approached next was to use monoclonal antibodies, so artificial synthetic antibodies, targeted against amyloid, against the little fibrils. So not so much the established plaques, but the beginning of where the little fibrils are beginning to polymerize together. And so those studies have been going on for some time now. And there was a drug called aducanumab that was very controversially licensed by the FDA in the US. It was not especially effective, and in fact, it's not available any longer.
What was controversial about it?
Well, what was controversial was whether it worked or not.
Okay.
And really, the experts were split on that. And it seemed to work a little bit, but not very much. And there were some people that thought it shouldn't be licensed, other people that thought it should. And it was people resigned. It was quite a controversial decision, but it was licensed. But what's important about that is that it sort of it opened the door to developing better versions of that. So many companies, big pharma companies, started to make monoclonal antibodies against amyloid based on the amyloid hypothesis that if you remove the amyloid from the brain, it will slow or maybe even halt progression. Yeah. And so just over a year ago in the US and here in the UK a few months ago, the second drug was licensed, which is lecanemab, and there's subsequently been a third one called donanemab. And they're all monoclonal antibodies against Alzheimer's disease. And it is very clear from the clinical trials that they slow the progression of the condition. If you look at the 18 months of the intensive treatment, not only does it remove a lot of the amyloid from the brain physically, but the rate of progression slows. Now, it slows by about a third over 18 months, but you may say, well, a third isn't that much, but actually it does look as though those curves might continue separating between the people on the placebo and the people on the active
beyond
drug.
The 18 months.
Beyond the 18 months.
Right.
And the other thing that's interesting is that those people that had a very small amount of amyloid, a very small amount of tau in their brain, so they were mildly affected, for some of those individuals, they seemed to stabilize and not progress. There were even a couple of people who, as I understand it, improved. So it may be, it's too early to say for sure, but it may be that what that's telling us is that if you treat people very early with these drugs, not only will it probably slow progression, but it may possibly halt progression. We don't know that for sure. That's unknown, but there's just a hint that could be the case. So, and if you look at decline in functional ability to do day-to-day things, it's about a 40% reduction in the decline. really exciting about this is that it's a proof of principle. It shows that there are drugs that do work to slow the progression. Are they perfect? Absolutely not, for various reasons that we can go into. They're not perfect. But there are a lot of new drugs coming through that will probably be better at removing the amyloid, and will probably get much better at working out how to give them. So I suspect in the future we'll have combination therapies. We'll have, a monoclonal antibody and maybe a gamma secretase inhibitor that will use drugs together. And the key seems to be treating people early. The reason that some of the studies probably failed initially is that they weren't treating people at an early enough stage.
Yeah.
If you treat people when they have quite advanced Alzheimer's disease, where there's a lot of damage and the cells, some of those neurons have died and the synapses have been disrupted, in a way it's too late.
Yeah.
You're not going to see a big difference. Whereas if you treat people at the early stages, that probably is where it makes a difference.
But that brings you back to the challenge of picking up a slow progressing disease without symptoms potentially for 20 years.
Right. I mean, at the moment, for these medications, probably only about 10% of people with Alzheimer's disease are suitable for them for various reasons. Maybe because they're not mild enough, because they're only licensed for either mild Alzheimer's disease or mild cognitive impairment due to Alzheimer's disease. So mild Alzheimer's dementia or MCI caused by Alzheimer's disease. But there are various other, contraindications and exclusions, including the genetic testing, but people who are on anticoagulant medication, blood thinners,
right,
which many elderly people are, people who've had a recent stroke, for example. But for those 10% of people who are suitable, they do seem to make a difference.
So who would be the ideal candidate for lecanemab?
The ideal candidate is somebody with mild symptoms, so they're not severely affected, somebody who is fairly fit in other respects, so they're not very frail and, with a lot of other medical comorbidities. They haven't had a recent stroke, for example. They're not on blood thinning medication, and they don't have this particular ApoE genotype, which makes it high risk. At least in the UK, we are not allowed to treat those people under the current licensing rules for lecanemab.
Is there an ideal age range for the ideal patient?
No, you can. It's sort of age agnostic. I mean, for people who are extremely elderly, of course, then they may be sufficiently frail that they're just not well enough. And these treatments require, they're quite complex to administer. So with lecanemab, it's an intravenous infusion. So these are antibodies that have to be given intravenously. And they have to be given every 2 weeks for 18 months. Thereafter, they're given at a lower dose once a month. Donanemab is once every month, so it's a little bit sort of less arduous in terms of coming into hospital quite so regularly.
Yeah.
But there are regular MRI checks that need to be done at different stages, particularly in the early phases of treatment, because one of the complications that one can see with these drugs is brain inflammation.
You mentioned that's
earlier. Right. You remember I mentioned it earlier on. Well, when the antibodies get in there, it sets off inflammation. And so you can get swelling of the brain. We call this ARIA, amyloid-related imaging abnormality. So it can be swelling of the brain, or it can actually be bleeding, because the amyloid is often in the blood vessels. And if you take it out of the blood vessels, they become leaky and you can get hemorrhages. So one of the requirements is that there aren't hemorrhages in the brain or signs of previous hemorrhages. So what are called microhemorrhages. You have to have fewer than 5 microhemorrhages.
Right. And lecanemab it's a new drug. It's not been around. How long has it been around?
Well, in the UK, it was licensed about 3 months ago. It's not available in most of the rest of Europe, but it's been available in the US for a little over a year. It's available in Israel and 1 or 2 other countries.
And we have it. I understand we're one of the few places in Europe that offer it at Cleveland Clinic London.
Yes, absolutely. We have a lecanemab service. So we offer lecanemab. We've built all of the infrastructure around that to set up the regular infusions and to do the monitoring with MRI scans and so on. So yes, for people that are suitable, we have a multidisciplinary team assessment process that we can assess whether somebody is a suitable candidate, where we need to make sure that they do have Alzheimer's disease, that it's the right level of severity, and they don't have any of the exclusions that we talked about. And then we can talk to them about the benefits, the potential benefits based on the clinical studies, and the potential risks, the ones I was talking about with brain swelling and so on. So we have a discussion about the risks and the benefits, and then it's really for that individual to decide whether it's the right treatment for them. But yes, I think we were the first people in Europe to give this drug. In fact,
fantastic.
I'm proud to say.
Yeah. And do you think we'll ever get to a point where we're just going to start giving drugs without symptoms just to prevent dementia onset?
Yeah, that's a great question, Kash. I mean, I think that's what's so interesting about this, is that what would happen in the future if I was to try and predict, it seems to me that if you've got a long pre-symptomatic period, firstly, where we know the amyloid is developing, but also if you've got a treatment that requires giving it as early as possible, is it the case that if you treat people before they even have symptoms, that you will delay the onset of those symptoms significantly, or maybe even stop it developing prevent it? And we know from various sort of socioeconomic studies that have been done that if you even delay the onset of Alzheimer's disease by 3 or 4 years, it makes a significant difference to the number of people that have it.
And clearly there is an economic and a financial cost to the treatment, the MRI scans, giving the infusions, the cost of the medication.
Right, exactly. It's an expensive treatment because it's a new treatment. It's a complex treatment. These are monoclonal antibody, and so it's not just, you can't just make it in a factory in the same way that you can with most small molecules. So it's a biological treatment that's difficult to make. So the drug itself is expensive, but it's also the costs of giving it, of having somebody come into the hospital every 2 weeks and be hooked up to the infusion and having the MRI scans and all of the monitoring that's required, make it an expensive treatment to give for any society.
Yeah.
But as I was saying earlier on, the costs in the US
absolutely.
of
$325 billion.
325 billion. So I would say, can we afford not to do this?
Yeah.
And if we can, I don't think it's an exaggeration to say that if we can slow the progression of Alzheimer's disease in people, particularly who are pre-symptomatic, I think it would alter the trajectory of human aging, because it's such a common problem as people get older. If you can do something to blunt that condition or even stop it progressing, it really would change, the whole way that people age, I think. And so,
and your quality of life into senior years.
Exactly, and your quality of life, because people can, the quality of life is so affected by Alzheimer's disease. So there are trials going on at the moment to treat people pre-symptomatically.
Right.
To see what happens. My prediction, I don't know, but my prediction is they'll be effective, that they will delay the onset or maybe even stabilize the condition in some people. And then if that comes to pass, then how do we, as a society, medical care, the health budgets are huge, absolutely, billions and billions of pounds and dollars. How do we afford to give these treatments to everybody that needs them? Well, and I think that will be really interesting, because I wonder whether these monoclonal antibodies will become easier to give.
And cheaper.
And cheaper. So the drugs themselves will become cheaper as more of them appear. They'll become more effective, most likely. And we'll also probably give them in a different way, because this is just the beginning of how we do things. But in the future, many of these drugs will probably be given as, little sort of like EpiPen type things, where you do a subcutaneous injection
like
using a little pen. Like a vaccination. You just do it into your leg, and it may be that a nurse will come around once every 2 weeks and do a quick injection, a jab into your leg. Or maybe you'll just do it yourself at home. Just give yourself these drugs as a monoclonal antibody at home. And you might need to have an MRI to get it checked from time to time. And people are developing much more efficient MRI sequences where you can do the MRI in 5 or 10 minutes rather than 30 or 40 minutes to check that there's no swelling in the brain. And so it'll be much easier if people are not needing to come into hospital every 2 weeks to have these treatments. If the treatments are becoming better, they're becoming cheaper. And I think, I can see a situation in which in the future we might be detecting early stage Alzheimer's with a blood test before it's symptomatic. Then maybe doing a PET scan to see if it's, there's clearly a lot of amyloid there. And then starting people on these medications in order to, prevent it from developing. And I think the other thing that may well happen is that you may remember that I mentioned, actual sort of immunizations, vaccinations against the amyloid protein.
In the transgenic mice.
In the transgenic mice, and then later on in humans. I think, that those probably people will start looking at how to do that in a more controlled way, because it does seem to work. It'll be cheaper, it'll be easier if we can do that. And, if everybody with Alzheimer's disease had these monoclonal antibodies, there aren't enough manufacturing facilities in the world to make all of the monoclonal antibodies that you'd need.
Yeah.
So monoclonal antibodies, they've proved that you can do it, but they won't necessarily be what we'll be doing in 10 years. There might be other things available. So I think we're on the cusp of a really interesting new era in treatment. And what we're doing at the moment is the beginning of that. It definitely works at the moment. I think it'll be easier, it'll be cheaper, it'll be safer in the future, and probably more effective. And that's really going to change things. I hope it changes things in time for me, as I get to the point where my own risk of Alzheimer's disease increases.
Yeah. Well, if you keep running your marathons, I think you'll be good. The thing that's fascinating about it, the thing that really fascinates me is that I really feel like we're on the verge of a transformative time and a paradigm shift in treating many conditions. And if we can prevent or treat dementia, then all of a sudden you are transforming people's lives over the age of 80.
Right. That's exactly right. That's exactly right. And as you say, it is a paradigm shift, and we are just at the beginning of a really interesting era. And it's not just for Alzheimer's disease. There are a lot of new treatments coming through for neurological conditions that were not previously treatable or more difficult to treat. And some of these very sophisticated technologies, immunotherapies like the monoclonal antibodies are one, but there are other sort of genetic type treatments, antisense oligonucleotides and other genetic treatments for conditions that were not previously treatable. So it's a really exciting time to be involved in these sort of things, and to certainly to be a neurologist. But throughout, we've certainly seen this in cancer over the last few decades, that some very complex, sophisticated treatments which have made some cancers curable that were previously untreatable, or given people much better quality of life, much longer lifespans. And we're seeing that in brain diseases now as well.
And we're really at the advent of AI at the moment. We're at ChatGPT 4.0 at the moment.
Right.
And the fact is, I think that AI, as it advances, is going to really revolutionize drug discovery and drug development.
For sure, yes.
And so I think we're on the cusp in the next 5 to 10 years, possibly, of changes that are unimaginable at the moment.
Yeah, I mean that's already happening. I mean the science that's done in drug discovery is already incredible.
Yeah.
And there's Nobel Prize for AlphaFold recently to predict the way that proteins fold. That's
was that the one that went to the DeepMind?
Yeah.
Oh, Demis.
Yes, exactly. Who was had been at Queen Square previously for his PhD.
Yeah.
So that's one example. But there are a lot of people doing really interesting work, looking at machine learning and predicting how proteins fold, or looking at the areas of proteins that you need to target for drug discovery. And once you've worked out which bit of a protein you need to target, it's like which small molecules will target that bit of the protein, or how do we design an antibody to attack it? So the way that drug discovery is done is clearly changing. It's not so much of a sort of just throw lots of drugs at the problem with a robot and try and work out what works.
Yeah, and it's something that tickled me. It's probably the first time in history it's been exciting to be a neurologist.
I'm not sure I'd agree with that.
I'm being unfair.
Neurology is fascinating. So many complex and interesting ways in which the brain goes wrong, and you as a neurologist, you get to look after people, and they're chronic diseases. You get to know your patients very well. You may have follow them up for the rest of your career. Yeah. It's just such a fascinating area of medicine. I think. Is it a cheap dig? Commend it to you, Kash.
Yeah, I couldn't resist just pulling your leg.
Of course.
So I think, Paul, we will encourage the listeners and anyone watching to support dementia research or activities. How can people find out more about dementia?
Well, there's a lot on the NHS website, for example, but in the UK, the Alzheimer Society is an excellent patient-focused society, a charity, and they have some really good materials on their website, or you can contact them direct and ask them to send you some written materials if you prefer. So that's a really good source of information to signpost people towards.
Okay, I'll put that in the show notes, and what I'll do is I'll also put a link to the Cleveland Clinic London website where we have some pages on dementia.
Right. Yes, and of course, for treatments of the sort that we've been talking about, we can be contacted through the Cleveland Clinic website, and if people want to talk to us about whether it's right for them or one of their relatives, we can easily arrange that.
Perfect. Paul, thank you very much.
Great pleasure. It's been a pleasure.
I really enjoyed this chat. Fascinating, and we're going to have more conversation in the future, I'm sure.
Thank you very much, Kash. Thank you for having me. It's been a great pleasure.